Thank you very much. I'd also like to thank the session chairs and the program chairs, Dr. Truss and Finelli, for asking me to be part of this. These are my disclosures. Most of what I do is in the world of endotherapy for obesity now, but I was part of the trial and work that went back 11 years ago for the original work in Barrett's ablation. What I'd like to do is talk about endoscopic therapies for treating Barrett's esophagus, review for some of them the efficacy and safety, and talk a little bit about the failures and what I think may be responsible for some of those failures and what we could do to improve it. These three photographs show Barrett's on the left, ablation in the middle, and restitution of neosquamous epithelium on the right. And in that neosquamous epithelium has been removed the markers, the biomarkers, Ki-67, P53, other biomarkers of cancer. This therapy in my career as a foregut endoscopist, this has really changed the way that we handle Barrett's, and I think it's been a remarkable story. The human esophagus, there are different target areas for these different therapies. Radiofrequency ablation does just under 1 millimeter of thermal therapy. It's really only focused on the surface layer there of the mucosa. PDT, photodynamic therapy, the multipolar electrocoagulations, and cryotherapies go a bit deeper. They're into the submucosa, as is endoscopic mucosal resection, and of course, endoscopic submucosal dissection, while full thickness resection is obviously in the realm of surgery. There are a number of older endotherapies that were used: PDT, argon plasma coagulation, the different thermal energies, multipolar and monopolar, heater probe, Teflon-coated probes, and even YAG lasers. And the problem with all of these, although they were successful in getting rid of some of the Barrett's, they had a mixed efficacy. They're often point-and-shoot devices. They're not very uniform. And it's possible to miss areas of Barrett's when you're trying to do the therapies. There was a high recurrence rate. And there were quite a number of adverse events, not the least of which some important side effects from things like photodynamic therapy, where you couldn't go out in the sun for a month, and patients were really bothered by their dermatitis that could happen from that therapy. Our current thinking about the management endoscopically of Barrett's starts with patient selection, and we'll talk a little bit about that, and patient education. And I spend quite a bit of time engaging the patient and understanding the multitude of visits that they're going to have. It's not like one visit, you come in, it's gone, and you'll never see them again. And they have this expectation that this could be a miraculous change. They will still be under surveillance, and you'll see why as we go along and understand the recurrence rates. We resect all visible lesions, and we must eradicate the remaining Barrett's esophagus. When it wasn't done that way, and just EMR was done as a principal therapy, Barrett's recurred in other areas because it's a mosaic disease and there were other foci of recurrent disease. We manage adverse events, so if there's strictures, we dilate them, we take care of the episodes of things that may happen from our therapy, and then, as I just mentioned, we continue in surveillance. So as we look at what we can tackle, we are potentially able to cure both the high-grade dysplasia and intramucosal carcinoma, that which is a T1A lesion that extends just to but not beneath and into the submucosa. Although there's controversy, we don't typically tackle T1B. Although if it was a well-differentiated tumor, and if it was not lymphovascularly invading, and if it was confined to the very SM1 upper layer of the submucosa, if it was a high-risk patient, maybe they wouldn't go to an esophagectomy, but maybe we would try to do some therapy endoscopically. And I think that we discuss these things in our tumor boards much like we discuss many other things together. I realize you may be not able to follow the details in this flow chart. It does project pretty well up there. The idea on flat mucosa, if you have non-dysplastic Barrett's, when you've done systematic biopsying, as we heard from Dr. Coachman, we would repeat the upper endoscopy in 3 to 5 years. 3 if it's longer segment, 5 years though if it's 2 centimeter Barrett's or so. You don't have to bring that patient back like we were doing 1 year and then every 3 years. That was probably way overdoing it based on the risks of non-dysplastic Barrett's. Indefinite, I would take it to the pathologist again and really find out, is this dysplastic or not? Because just as Mike suggested, if there is dysplasia, if there's indefinite dysplasia bordering on low-grade dysplasia, then that person is probably heading into the category where we would do endoscopic therapy, and we're going to follow them a lot more. Confirmed low-grade, we can treat and eradicate with ablation, high grade as well, and T1A esophageal cancer. Now, if there's nodular disease, you must do an EMR. You have to take off the nodule. And once you've done that, if there's low-grade dysplasia, we treat. High-grade dysplasia, we treat. T1A, as I mentioned, we treat. T1B, we would talk about it. And those are the latest guidelines. If you're going to do endoscopic mucosal resection, it's done for staging. Let's find out what's at the margins of this nodule. It's focally resective, and we can do piecemeal wide field resections. You can take off half the circumference of the esophagus in the areas of Barrett's at any one session, reducing the likelihood of stricture. If you go all the way around, you will certainly cicatrize that esophagus. And if you do EMR, it's typically either with a band snare or an injection and snare device that's done in a cap at the end of the scope. You pull up the tissue, making it sort of polypoid, and then resect through that. And that's the typical EMR. Now, the outcomes from EMR for complete eradication of dysplasia and neoplasia have ranged incredibly well in the almost 90 to nearly 100% range. But the recurrence of dysplasia or neoplasia, when that was done alone, was just about 6 to 30%. You must do then ablative therapies like RFA or cryotherapy following the EMR, following its healing, following the use of PPIs for about 8 weeks and bringing the patient back. The outcomes are similar to surgery. Causes of recurrence were large lesions, long segment disease, piecemeal resections where you might miss an area of the esophagus containing the Barrett's, multifocal neoplasia when the RFA or other techniques were not done to be complementary to the EMR. And mainly, there was incomplete ablation of the Barrett's tissue. EMR can also be used to treat recurrence. So if you find nodular disease that's come back, you mark the area, as you can see in the upper right-hand corner, and then you resect it again with another EMR. So it can be also therapy to rescue recurrent disease. What about ESD? If EMR is good, what about if we took wider areas by dissecting under the mucosa and pulling up a big segment? And that has been successful to treat high-grade and esophageal cancer, where you see, in the range of 60 to 70%, nearly 80% successful resections of the disease, but recurrences, again, of 5 to 8% at 2 years. And the real problem is safety. About 30 to 60% of patients can develop strictures, and if you get into submucosal dissection, you enter the world where you best be able to handle the perforations that are going to happen. If you ask the question, is EMR inferior or equal to ESD, here's a study that suggests it's not inferior to ESD, endoscopic submucosal dissection, for early Barrett's. And in fact, it produced similar results with the same type of bleeding or perforation or recurrence rates, and it took a lot less time. Using the multibander EMR device, the technique was considerably less time-consuming and gave equal efficacy. In the U.S., ESD hasn't really taken off, mainly because of the time constraints and the training issues related to it, and many people have access to doing adequate EMR. What about radiofrequency ablation? So this is a very well-designed technology in which tightly spaced electrodes generate only a certain defined, about an 800 micron depth of thermal injury. Beautiful to get through the mucosa and into the very proximal submucosa, but not much deeper. You have a defined generator. There are circumferential balloons for long segment circumferential disease. The latest is the far right, this express catheter, which is a sizing balloon and the therapeutic electrode balloon all in one. So it does save some time and is adequate for any sized luminal esophagus. There are focal ablators that come from 4 centimeters long, the ultra long one, to 2 centimeters in the 90 or shorter in the 60, and even a through the channel electrode ablator that can focally ablate areas. And if you have a strictured area of the esophagus or a narrowed esophagus, or somebody who might have had eosinophilic esophagitis with a fixed esophagus, you can get your scope through and put your ablation catheter through your scope. It's really been a great tool to have in some of the difficult esophagi that we see. Circumferential ablation, you're basically moving from top to bottom. ablating about a 3-centimeter segment. With the new device, it's a 4-centimeter segment, top to bottom. So if you have 8, 10-centimeter Barrett's, or as we tackle sometimes, 16-centimeter Barrett's, you can just move from top to bottom, overlapping about 5 millimeters as you move down the esophagus. The delight is that the patient goes home after a 20-minute procedure and they no longer have their Barrett's, they no longer have their dysplasia, they may no longer have their IMs, their intermucosal cancer because you've taken that off. And then there's focal ablation, which can just touch up areas that you may not have gotten after the circumferential ablation. Well, let's look briefly at some outcomes of RFA, and here you see it's about a 91% overall success rate of complete eradication of dysplasia. Now, this takes all comers, and this is really first-line therapy, not recurrent rescue after recurrence line. And you can see there's heterogeneity throughout all of the studies. And there have been many, many studies, but this is a recent meta-analysis. If you look at complete eradication of IM, of metaplasia, it's around the 76% line. And it's easier to get rid of dysplasia than it is to get rid of all Barrett's. Now, when we talk about this means come back, do a series of biopsies, and any one biopsy out of what might have been 80 biopsies, if it had one smidgen of Barrett's, it was considered a failure to have eradicated that Barrett's. Or if it comes back on one biopsy, no matter how many biopsies are taken, that's a recurrence that could happen. The failures, it's about 13% overall, but again, that's one biopsy out of all the biopsies. And recurrence rates, here's a recent study that was published by the Mayo Clinic group looking at a meta-analysis of more current studies than the 2013 studies I just alluded to. 21 studies, 3,000 and above patients. There were 603 recurrences of metaplasia in over 5,700 years of patient follow-up. Recurrent intestinal metaplasia was about 10%. Recurrent severe dysplasia or early IMC was 1.2%. Those are the rates of the most current data that we have. Here's a study from University of Pennsylvania, where Mike is from. There were 246 patients, and they were asking the question, does it matter whether you started out ablating a high-grade patient or a patient with IMC in terms of recurrences? And here you see no difference in the recurrence of dysplasia or neoplasia, which originally was at the first few years at about 9 or 10%, but actually goes up in a few patients who've made it out now almost 10 years to nearly 25%. And no difference whether you started out with high-grade dysplasia or IMC in recurrence of any IM, which again was in about the 20% range early on, but accelerates up to almost 50% recurrence in this well-done series. If you look at a real-life series, which is a cohort of almost 5,000 patients done at 130 centers that are a mix of community hospitals and academic centers, 100 patients developed esophageal adenocarcinoma. That's 2%, but only 0.2% died of that because it was found, it was treated, and this was a follow-up of about 4 years. So there's a real-life experience in a multitude of different locations. Safety of RFA, you can see strictures. The pooled rate is 5%. It's typically less than that, but that's from the published data. Pain and bleeding are things that may be seen with RFA. Finally, a few words about cryotherapy. Cryotherapy comes in either liquid nitrogen or carbon dioxide. You can spray it. One of the problems with it is it gets in the front of your endoscope and it makes it kind of difficult to see where you are. The latest entrant into this over on the right is actually a CO2-filled balloon that you use with a device that shoots a cartridge basically of carbon dioxide, and that way you can see what's going on, and the cryogen is actually inside a balloon and contained, and you can lay it up against the Barrett's. Very new. We don't really know its full outcomes yet, but the outcomes that we know that are there, because freezing therapy, it actually happens that you damage the cells in the thaw. So we freeze and then we thaw, and you do that repeatedly, and that causes cellular damage, and then it'll just look hyperemic at the end of the therapy, and then the patient goes home and they slough. And during the next couple of months, they'll heal their esophagus and create neosquamous epithelium if they've been on their PPIs. And the outcomes looked pretty good in this short study of only 32 patients, but they were quite good at getting rid of both dysplasia and intestinal metaplasia, dysplasia in blue, the IM in the cream color. And here's another study of about 96 patients, 2-year follow-up. Again, multi-center, and they were able to get rid of dysplasia in the light blue and any metaplasia in the dark blue over a period of 2 years in the range of where RFA was doing. But here's a study from Europe that basically they abandoned it halfway through, saying that the cryoablation was, with CO2 was not effective, and they terminated their prospective trial. And I think that the data is mixed, and there's a lot less experience so far with cryotherapies, but it is useful for patients whose anatomy will not allow RFA, or it can be used in actual cancers of the esophagus. There's reasons to have cryotherapies in different units. So let's just talk for the last minute about features related to endoscopic failure to eradicate Barrett's. Female gender, long segment intestinal metaplasia, the need for a long number of treatment sessions, high number of treatment sessions, persistent esophagitis that won't heal. And so I typically will send these patients then for a Nissen fundoplication in the middle of our attempts at eradicating them, let them get their treatment for GERD, they come back, and then you can finish the ablation. These are patients who are refluxing non-acid as well as acid. They just have a wide open esophagus, big hernia perhaps, and they need to have that attended to before we can finish the treatment sessions. A large hernia, as we said, uncontrolled acid of each kind. So the pooled data on recurrence, again, 41 studies, 4,000 patients, 795 IM recurrences, over 10,000 patients' years of follow-up. Recurrent IM, 7%, recurrent high-grade dysplasia or cancer, 0.8%. Why? The last thoughts I have are because maybe we don't do it as well as we should. There is a learning curve for RFA. That's about 30 cases. When this was studied, that reduced the number of sessions to ablate the esophagus. On the other hand, there was no effect on the recurrence rate when that was looked at or on safety issues. But I don't think that we look well enough for neoplasia. And Mike was talking earlier about how to recognize lesions and spending time. We do need to do systematic endoscopic inspection, more time inspecting. So here's an interesting piece of data. The Amsterdam group showed that up to 80% of patients referred for workup of high-grade IMC who were claimed not to have visible abnormalities by the community physicians found them by expert endoscopists, 80%. And I show you their micrographs, their photographs. On the right, they circled all of the findings that were there on the left side and missed by the community physicians or less experienced physicians. You know, being a Barrettologist or an esophagologist focused on Barrett's, you're really spending time looking at this. Here's the correlative data on that. If you spend greater than 7 minutes in long segment disease, you find the suspicious lesions. This was a almost linear relationship to the amount of time spent. And here is a graph actually of spending on the left less than a minute per centimeter, or on the right greater than a minute per centimeter, and the amount of findings, not only of lesions, but of suspicious and bad lesions. So we do need to spend more time, and there's the linear relationship. So it's basically a minute per segment of Barrett's. So if you have a 7-centimeter segment, you're looking for these lesions for 7 minutes. I think that's the reason why there's recurrence of cancer after doing RFA or after these therapies, because those lesions were probably there before the person even, before we didn't clean it and get it flat and get it gone of all lesions beforehand. And this is the last piece that I'll scare you with, which is that most cancers are found early. 25% of esophageal adenocarcinoma are diagnosed within 1 year after an index endoscopy. And in this particular look of a meta-analysis, they were probably there and missed. If they were found 1 year after the index endoscopy, they were probably there. So a quick, hurried endoscopy that didn't find it is going to have it show up again. So we need to do what we can to make that better. Lastly, there's a very interesting model that was just published of the cost effectiveness treating high-grade patients. It was a modeling of a 65-year-old person with a high-grade dysplasia. And as you can see, the quality of life is excellent for either esophagectomy or EMR, and better than following that patient by surveillance, but it was more cost-effective to do it by EMR or RFA. So I leave you with that thought because you, like I, am very interested to hear the next talk about how we find the role of surgery, because you've heard this talk from an endoscopist from New Hampshire, and I'm very interested to hear what our surgical colleague will say. Thank you.